So first of all, I want to thank the six programs. Thanks for CUNY and my awesome mentor, Dr. Tommy and Dr. Solomon. So my topic today is an analysis of the association between reproductive factors and subtypes of breast cancer in Nigeria. This is the outline of what I will talk about today. I will go through from background and objectives, methods, to my future career goals and plans. So as McDowell and Christine, they already talked about the importance and the severity of breast cancer. I will not repeat that. So, but I do want to mention that breast cancer among African American patients is believed to be more aggressive and tend to be estrogen receptor negative. So regarding the subtypes, according to the expression of estrogen receptor, PR, and HER2, breast cancer is divided into 4 different subtypes: luminal A, luminal B, HER overexpressing, and triple negative. It does have different classifications, but this is the most common used ones. And a little bit background of reproductive factors. Common reproductive factors include age at menarche, pregnancy, parity, age at menopause, hormone replacement therapy, hormonal birth control. Generally speaking, later age at menarche, early age at menopause, and longer duration of breastfeeding, and higher number of parity are protective women from getting breast cancer. But actually, according to the systematic review we did, it's different from different subtypes and different populations. So the reason why I want to conduct this study is like African women, they tend to have triple negative breast cancer, but actually the reproductive factors they have is tend to be protected because they have more children, their age at menarche a little bit later. So I'm wondering why that is different. How does reproductive factors influence the breast cancer subtypes in Nigeria women? So my objective of this program is to obtain field experience in breast cancer research, to collect epidemiological and clinical data on reproductive risk factors and breast cancer subtypes, and also want to conduct literature review regarding this association, and last but not the least, to conduct data analysis regarding the association and try to publish a paper. So this method, Dr. Tommy already talked about it yesterday, so I will just focus on the part I participate in, but I will briefly talk about it a little bit. So once we have newly diagnosed breast cancer patients, we will introduce our program to them to see whether they want to participate. If they do, we will get the consent form, and we will administrate surveys which includes demographic and reproductive and other risk factors, and also mental health information. And we also will try to get some samples like blood samples, saliva sample, and tissues for biopsy from our participants. And after 1 year or 2 years of enrollment, we will do follow-up interviews, which includes their vital status, their recurrence, and their treatment. So the part I did is to review patients' medical records. It was struggling at first time because it's all handwriting, and it was so hard for me to recognize those handwritings. But I'm really thankful my colleague Rebecca, she helped me all the time to recognize those handwritings. So for this review, we abstract their disease-specific information, including their stage, the size, and the grade. For treatment, we will see whether our patient get chemo, whether they get radiation therapy or surgery, and if they get what specific chemo they get, and how long, how many courses. For the pathology, if they did pathology test, we will try to get their histopathology report. This is the first big part I did this summer in Nigeria. The second one is the systematic review regarding the association of breast cancer and reproductive risk factors. So firstly, we get 6,505 papers after removing duplicates. We got those records through a different database, includes PubMed, Embase, and through title review, we excluded 6,379 papers, and which left us 126 papers. And then through abstract review, we excluded 21 papers and left us 105 papers. Lastly, through food test review, we excluded 7 papers, which left us 98 papers in total. So unfortunately, we are still waiting for the immunohistochemistry results, so I will just gonna represent some initial results of how many samples we get and how those reproductive risk factors distributed in our patients. So for this Luth is the site I participated in. So we got 103 interview information, 87 blood sample, 92 tumor by using Paxigene solution, and 90 tumor tissue for cryoview, and 46 normal tissue for Paxigene, and 8 for cryoview. We also get 58 saliva sample. Among our, when we talk to patients, we also get some refusal, like a few patients, they don't want to participate. For the general distribution of our reproductive characters, I will compare our site to US, African American, and other races. But I will just focus on the percent because the sample size are different from different studies. For the age and monarchy, our mean is 14.4, which is higher comparing to African American and other races, which should be protected. This is the kind of same to the age at monarchy, which is there is smaller than other races. For menopausal status, 60% of our patients belongs to the category of premenopausal and perimenopausal, which is a little bit higher comparing to African American, but it's kind of similar to white people. Regarding the pregnancy, we have 88.4% of patients ever get pregnant, which is kind of similar to African American and white people. For the live birth, our mean number is 3.7, which is higher compared to the median of African American, which is 2, and higher than the Hispanic African American, which is the median is 1. For the other two left variables, which is hormone replacement therapy and hormonal birth control, for the HRT, none of our patients ever get that, which is totally higher comparing to African American and white people. So these two should be protective as well. But how it's different from subtypes? So that's why we need to focus on my future analysis. So for this study, we are waiting for the subtype results. Hopefully we can get in 1 month. If we do get by time, and we try to finish our analysis regarding dissociation in 3 months. For the literature review I've been doing, I'm extracting the data now. So I think it can be done in 2 weeks, and we plan to finish the meta-analysis in 1 month. My little bit learning experience. So I think details of a research program are subject to change. So being prepared is really essential. And collaborations, as all other students mentioned before, is really important for doing research. this third one, I think I definitely get this one from Dr. Tommy. So like work schedules could be intensive. You just need to be ready to sacrifice your time. So my dream work before, I just want to work from weekdays, Monday to Friday, and 8 hours every day. That's what I planned to do before. But now I think I already changed my mind because you have to work on weekend or your vacation sometime. If you want to really be a researcher, I do believe I should sacrifice my time sometimes. So lastly, cultures are different in different countries, regions, and even different settings. So for me, being open-minded is super important. Possible research topic for future students. I believe students could conduct some other important risk factors in Nigeria. They also can continue collect additional data regarding the treatment and follow up to determine the association between subtypes and prognosis. Strengths and limitations of our study. I do believe it is absolutely the strength is overweigh the limitations because it is the first research of this topic in Nigeria, and the data we collected are comprehensive. It includes different information like demographic, risk factors, and biomarkers, and DNA stuff. And I think it is representative because we have different sites which distributed in different state in Nigeria. But it is also one of our limitations, I believe, because it is located in big city, and parts of local people, they don't get a chance to access to this treatment and those diagnoses. And our follow-up rate, I would say, is a little bit low. So lastly, my future goals and plans. I plan to apply for my job back in China after graduation in this December. Hopefully, I could be an epidemiologist in CDC or a statistician in pharmaceutical companies. And I do want to get a PhD degree, but I just think I need time to figure out when I want to get that. I need some time to see how work goes first. So this is my reference, and I want to spend a little bit time to thankful for my mentor, Dr. Tommy. She supported me academically and personally. And my colleague, Rebecca, she walked me through a lot of different stuff and different cultures in Nigeria. And Dr. Lola and Dr. Adeniji, who helped me go through those medical records first, because first of time, I'm not familiar with those medical terms and those handwritings, so they spent a lot of time with me to walk me through the first few records. Okay, that's it. Any questions?
Thank you. Very nice presentation. I've done some work in Nigeria, so I can appreciate the challenges. I'm always concerned about epidemiologic work from Nigeria when one tries to establish representativeness of your sample. Granted, you mentioned that you're only dealing with urban populations, so you're probably missing other parts. But even within the urban population, are you getting the totality of the breast cancers, a representative view? And if not, what are the factors preventing that?
So, could you repeat your question? Sorry, I didn't get it.
So you acknowledge your sample only represents urban areas.
Yes.
But even within urban areas, do you think that the breast cancer cases that you've reviewed represent all of those cases within the urban area? And if not, why not? What are the factors?
Okay, so firstly, outpatient, I believe most of the outpatient is from urban areas. And it is, I believe it's representative because it's from like different states. And we do get like and outpatients from different tribes and not just like Yoruba only. So that's why I think it's representative.
Well, you have issues in Nigeria of insurance or lack thereof.
Yeah, most of patients don't have insurance at all.
Right. So that limits how many
Yeah.
show
yeah.
up for care and the level of care that they receive, and also the number of individuals who go to private hospitals for treatment, not to the major facilities that you're working in.
Yeah, that totally makes sense. Thanks.
I was going to say it's very impressive, all the stuff you were able to do. I mean, that's an amazingly comprehensive study. And the fact that you were able to do this huge meta-analysis too, those are two really significant skills that you learned from this. That's really good. But I had a question, not about this subject, but about, if you're going back to China, what's the status of breast cancer in China? Especially, you know, is it still the sort of one-child sort of...
So I think it is one-child policy. It is until 2016. So now it's open to 2 kids. But the problem is because like we have a lot of population and people are stressed to get like good jobs. So people they have financial issues. But even though we have 2 children policies now, a lot of young people try to just get one. Yeah.
So, but is breast cancer, because there's a lower birth rate, is breast cancer different in China? Do you, this is just your gestalt observation?
Actually, I don't really know because I didn't really research how breast cancer did in China. But I believe for the parity, we do different from like United States and Nigeria.
Just a comment about the one-child policy in China. It turns out that there's a little bit of a myth and legend about that. First of all, in rural areas, people may have more than that, but the more significant observation is that if you look at the birth rate in Brazil, the birth rate in Brazil has dropped more than the birth rate in China since they adopted the One China policy. The birth rate everywhere in the world has been plummeting over the last 4 or 5 decades. My grandmother had 11 brothers and sisters. Those families don't exist anymore. And so because of the visibility of the one-child policy in China, we tend to think that's an outlier in terms of family size. But in fact, the birth rate everywhere in the world has been dropping like crazy, and China is not even the champion for dropping of birth rate through adopting that policy.
I just wanted to respond to the comment about representation in Nigeria. So you're right that in most studies where they do case series in hospitals, it's going to be a convenient sampling of who shows up. And but what's good about this hospital is it's a federal government hospital, it's a tertiary hospital, and it's also a teaching hospital. So care is supposed to be free, although they find ingenious ways to charge patients. So we do see a broad range of socioeconomic status, patients from different socioeconomic status. But the other challenge is the radiotherapy machine doesn't work. Sometimes the lab is not functional. So there's a lot of gaps in the treatment that's received because some people get diagnosed formally in the hospital, then they go to the private hospitals for specific treatment. A lot of people travel abroad, they go to India or they come to the US. So we're going to be missing a lot in terms of treatment and actually follow-up from the higher SES people. The issue from the lower SES is a lot of traditional beliefs about cancer and treatment. So a lot of times they come, they get the diagnosis, and then they leave, and then they go to the church or other religious settings to do other approaches. So the data is limited, but which is why the design is when there's a first suspicion of breast cancer is when they get recruited. So we don't actually wait for the pathology report because many people don't come back. And then we do our pathology reports and then remove the non-cancer